And hello to everybody who's listening. This would have been what one might possibly be able to call a practically orientated talk during the current crazy COVID crisis. Unfortunately, I would say this is more of an abstract topic now, given that none of us are allowed to do any elective operating, and given that even trying to get something urgent done has become incredibly difficult. So we can only pray that the numbers continue to drop and that elective work does begin to recommence sometime soon, because otherwise the waiting lists are just going to be unmanageable and it's going to take the UK years, not months but years, to catch up. But let's focus on the topic for today, which is meniscal tears, trims, repairs and replacement. For me personally, if you want to know more about me, I'm a consultant knee surgeon based in London, full-time private, have left the NHS 10 years ago, do nothing but knees, with particular specialist interests in meniscal repair, meniscal replacement, and also arthroplasty with custom-made knees. So if you do want to know more about who I am, what I do, then simply check out the website and all the full details are on there. So we're going to go through this quite quickly. It's quite difficult to go into any real detail because Adit's asked me to do approximately 20 minutes talking and approximately 20 minutes Q&A. So we're going to fly through this quite fast. Apologies if it's too simple if you're a surgeon listening, and apologies if we go too fast, but I'll try and do my best. So first of all, what are the meniscal cartilages? So that's the tibial plateau of a left knee with anterior down here, and so you have a medial tibial plateau and a lateral tibial plateau, and the meniscal cartilages are two C-shaped elastic fibrocartilage wedges, a little bit like the outside part of your ear. The medial meniscus is more ear-shaped, the lateral meniscus is more C-shaped, and they sit between the femur and the tibia. They're made of bundles of collagen, and people talk about a red zone and a white zone, and this is relevant for later in the talk. So the inner 2/3 of the meniscus we call the white zone because it has very poor or almost no blood supply. The outer 1/3 has a reasonable blood supply, not great, but reasonable blood supply, and we call that the red zone, and that's relevant when it comes to meniscal repair later. In terms of how it actually works, well, the femur, the end of the femur, is a curved surface sitting on a relatively flat tibial surface, and the meniscus sits in between as two little wedges, like a cushion, and what it does is it increases the contact surface area, therefore spreads the load, decreasing the peak contact pressures. Obviously the average contact pressure is still the same, but the focal peak contact pressures are distributed in a wider surface area and therefore lower. And that's very obvious when you take the meniscus away. So if there's no meniscus, then you've got point loading, curved surface against a flat surface, small surface area, very high peak pressures. And studies have shown that if you completely remove the meniscus, then the peak pressures go up by 236%, which is huge. So if you think of the meniscus as being like a slippery little wedge between the femur and the tibia, then as the femur pushes down, it tries to peripherally extrude the meniscus outwards. While the meniscus is attached firmly at the front and the back via its insertional ligaments to the bone, and those ligaments are very, very stiff and very strong. So the meniscus can't be extruded much. It can only stretch so far before you develop tension in these circumferential collagen fibers. So what people talk about is axial load being converted into hoop stresses, which is not quite the right biomechanical terminology, but that's what people say, hoop stresses within the meniscus. Now that's only ever going to happen if you have continuity all the way from the bone through the insertional ligament, all the way around the meniscus, back to the next insertional ligament, back to the bone. If there's any discontinuity in those collagen fibers, then you will not develop tension and the meniscus will not function properly. It will simply be peripherally extruded. So hopefully this is demonstrated nicely on these little pictures here. This is from one of the studies we did with Andrew Amos at Imperial College quite a few years ago now. So this is pressure-sensitive paper put into the lateral compartment of the knee, first of all at the top here with the meniscus intact, and then underneath what we've got here is this is what the pressure profile looks like when you take the lateral meniscus out. Smaller contact surface area, much higher peak pressures. And what does this do? it increases the wear rate on the articular cartilage. So eventually you get wear and tear, degeneration, it wears away, you end up with bare bone, in other words, arthritis. The best paper out there for quantifying the increased risk of arthritis after meniscectomy is probably this paper by Roos and Roos in the Journal of Rheumatology from back in 1998. And what they showed that if you completely remove the meniscus, then the relative risk of arthritis 21 years later goes up 14 times. Now, an easier way to remember that is roughly 20 years later, there's a roughly 15 times greater risk of arthritis. And if your patient doesn't seem like they're taking that seriously, well, you just tell them that's a 1,500% increased risk of arthritis, and then it really puts it in the picture. So how do these important meniscal cartilages tear? Well, broadly speaking, you can divide them into two categories. First of all, traumatic, and we all know that the best way to tear a meniscus is to twist on a bent knee, and that's particularly in sports such as netball, football, rugby, squash. But if you have a degenerate tear, and very importantly, the meniscal cartilages do not remodel, and that's been shown very nicely in a recent paper that was published where they did carbon-14 dating on the actual collagen fibers. So as you get older, the meniscus does not remodel. So as you get older, it becomes degenerate, just like a rubber washer perishes, and with time a tap can start leaking spontaneously. Likewise, if you've got a degenerate meniscus, then it becomes friable, weaker, more liable to tear, and 50% of degenerate meniscal tears occur spontaneously with no history of any trauma at all. If there is a history of trauma, or if the patient relates it to a particular episode, then quite often it's getting up from a bent position, such as if the patient's been kneeling on the floor. But 50% occur with no trauma, so don't let that one catch you out. And if you do tear a meniscus, there's lots of different types of meniscal tear described. So radial tears, horizontal tears, flap tears, parrot beak tears, bucket handle tears. It's not massively useful because it's very descriptive, but we do use these phrases, and the relevance really comes in whether the meniscus is likely to be repairable or not. So moving on to when to operate. Well, easier to start with saying, well, when not to operate, when to leave alone. And this is fairly clear and fairly obvious. If you've got a patient who's older with a degenerate tear that's occurred spontaneously, then they're far less likely to end up needing surgery compared to somebody who's young with a meniscus that was otherwise normal but has suffered trauma through a specific accident. So traumatic meniscal tear is much more likely to need surgery than degenerate. Again, likewise, older people, you're more likely to leave them alone compared to younger people. If you've got somebody who's 85 years old with lots of comorbidities, who's not very fit, not very active, doesn't really do much apart from sit in the chair in a nursing home, but they've got a meniscal tear, you're very unlikely to operate. If you've got somebody who's an 18-year-old who's just going into a career in professional sport, then you almost certainly will. Next, very importantly, if you have a patient who's got advanced arthritis, so degenerative changes, arthritis in their knee, then the more damage there is in the joint, the less likely that patient is to be an appropriate candidate for an arthroscopy. And there's been an awful lot in the press about this recently over the last umpteen months. But very frustrating, really, because this is just not rocket science. It's telling us how to suck eggs. Anybody with half a brain already knew that doing a washout, just putting a telescope in, washing out the joint, getting rid of the debris, in an arthritic knee is a pointless thing to do. If it gives any pain relief, it's going to be marginal and only temporary, and not worth the pain, the hassle, the risk of the actual surgery. But we all knew this. If, on the other hand, you have a patient who is developing degenerative changes in their knee, and they have rough or loose bits of articular cartilage, they have an unstable symptomatic meniscal tear, then there's a lot that you can do to tidy up the joint. And that can reduce a patient's symptoms, and it can keep them going, buy them extra time and delay the time when they need more major surgery like a knee replacement. So this is not rocket science, and it's simply telling us what we already knew. Then it's all about the symptoms. Well, if somebody's got a meniscal tear and it's not really bothering them, then fine. It's very difficult to justify the pain, the hassle, the risk of surgery if they've only got minor symptoms. And if they have no mechanical symptoms, particularly if it's a degenerate tear, again, you're more likely to urge conservative management. And if it's a low demand patient, also if they've got lots of comorbidities, and fundamentally if the patient's not that fussed. When you talk to a patient face to face and you start talking about surgery, and they're sitting there and they're going, folding their arms, looking back, chin down, shaking their head, well, you know they're not keen. If you talk about physiotherapy and conservative management and they're nodding and they're engaging, then it's blatantly obvious which way the patient is going to go. And at the end of the day, we're simply there to give patients advice, and the final decision is the patient's. If they're not fussed about their symptoms, meaning their symptoms are minor, then you shouldn't impose your concerns necessarily and urge them to have surgery. So, flip side of that, when should you operate? Well, it's just almost the exact opposite of what we've just gone through. So, traumatic, more likely than degenerate. Younger people, more likely to operate compared to older. Major symptoms versus minor. Mechanical symptoms like giving way and blocking. High demand patient, so an athlete. And if somebody's got a locked knee. So if you have a patient with a locked knee, then that's a different category. That patient is now, it's not an emergency where the patient has to be admitted then and there the same day and taken to theatre that day or that night. That's an emergency. It's an urgent, and that means ideally the patient needs to be sorted properly within ideally a number of days rather than weeks. That patient needs an MRI scan and they're going to need an arthroscopy, because a locked knee is a displaced locked bucket handle meniscal tear until proven otherwise. So if somebody presents to me with a locked knee, they'll get an MRI scan that same day and they'll go to theatre within a couple of days ideally. And this is what it looks like when you've got a locked tear. So this band of tissue sitting in the wrong place, we've washed out the knee here, and that is the displaced bucket handle fragment of the meniscus. And then we've pushed it back in place. We've had to pie crust the MCL to open up the medial compartment to allow this to go back into place. And then we've stitched the meniscus back in place, and that's been salvaged now. That little yellow area is simply where a very small radial tear in the inner free margin was trimmed slightly, just minimally, and then smoothed off with a radio frequency probe. But that meniscus has now been salvaged instead of binned. Very importantly, if you leave a displaced locked bucket handle meniscal tear for, and this is very arbitrary, but people say 6 weeks, if you catch it within 6 weeks, you've got a good chance of being able to reduce it, repair it, salvage it. If you leave it more than 6 weeks, then the longer it is left, the lower the probability of being able to reduce it, repair it, and keep it, the greater the likelihood of the patient ending up with what would effectively be, in most cases, a total or subtotal meniscectomy. So don't leave a locked knee. In terms of general guidelines as to when to operate, well, this is the definitive paper published in the Bone and Joint Journal last year, and this is the results of the working party from BASC, the British Association for Surgery of the Knee. And their guidelines, if you glance at it, it may look a little bit complicated to do it, is actually very, very simple. And this simply tells us what everybody already knew. There's not rocket science, but the team from BASC who actually put this together put a huge amount of effort in making sure that this was all evidence-based from the literature. So, repair. If you have a meniscal tear, then a majority of the time, the way that we repair these tears nowadays is called all inside, which means that you don't have to make big cuts, and the stitches are all done arthroscopically with special instruments. So what we tend to do is we use a slotted needle with 2 little anchors inside, and we push that needle through the meniscus one side of the tear. You pull back and it leaves behind a little plastic anchor that wedges in the capsule, and that stays there for good. Attached to that anchor is a non-absorbable thread. Then you load a second anchor and you push the needle through the other side of the tear. Again, the anchor wedges on the capsule and stays there for good. And attached to the second anchor is a second suture, and the 2 sutures are attached to each other by a slip knot. So then what you do is you pull on the suture whilst pushing on the knot, and as you do that, it tightens up the slip knot, which squeezes the meniscal tear together, and then you cut the suture, and that's your meniscal repair done. So that's an all-inside meniscal repair. Now, everybody's got their own preferences. Every surgeon's got their own preferences. Sorry, in terms of what kit they like. My personal preference is the Striker Air system. The original version, probably most of these have evolved from the Smith & Nephew Fast Fix. But the advantage of the Striker Air version is that the needle is bendable. You can actually bend the needle by as much as 90 degrees and it will still fire the anchors successfully. So you can get to pretty much any portion of the meniscus apart from the very most anterior part, the anterior horn. But you can get under the meniscus, over the meniscus, round the meniscus, and this is an incredibly useful bit of kit. Now, I hope this video is going to play. This is a demonstration of a meniscal tear. Alid, please tell me if it's not clear enough when it's coming through. And what we're looking at here is the medial compartment. Now, there's a tear there, confirmed clinically, confirmed on MRI, and my probe is disappearing into the tear, but there's very, very little gap. So what we're doing here is we're pie crusting the MCL, which means getting a needle and from the outside poking the medial collateral ligament and the posterior oblique ligament, which is just behind, whilst putting the knee under a valgus pressure. And what happens is the MCL gives. So you're creating effectively a minor partial tear of the MCL, and as that gives, the medial compartment opens up by a few additional millimeters, which is all you need to then be able to see and do what you need to be able to do. So now we've pie crusted the MCL, you can see there the meniscal tear much more clearly. Now this patient, if you look at their femoral condyle, they've got some damage that's already been tidied up. And this meniscal repair is on the edge of what would normally be considered acceptable, because this is not a particularly young patient and the meniscus is slightly degenerate and there's some partial thickness cartilage damage on the medial femoral condyle. So what we do in this situation sometimes, after having properly consented the patient, is to attempt a repair, and if the repair goes well, then we continue with it. So every stitch you put in is looking better, then you carry on. Sometimes, when you try to repair, then every stitch you put in, the meniscus falls apart. So it is looking worse, in which case you stop, you take the stitches out, and you just go ahead with a partial meniscectomy. So that's the first anchor put in, and here's the second anchor being put in. And I'll speed this up a little. So then you pull back, and then we haven't tightened that stitch yet because I don't want to pull the meniscus down. I want to maintain that view that we've got. So now we're putting in a second stitch, first anchor, second anchor, and a third stitch, first anchor, second anchor. And then what we do is we pull on the suture, push on the knot, tighten it up, and it pulls the meniscus back together. So that's 3 stitches on the tibial undersurface, each being tightened individually and cut. Cut. And then 3 stitches on the femoral upper surface. And these are tightened one at a time as you go. So that's the slip knot going, and slide down and cut. And then we have the third one, and that stitch has come around quite anteriorly because we've got the Striker Air, which is bendy. And then the inner free margin of the meniscus is being tidied up with a radio frequency probe, and everything's being smoothed off, and that's our final result. I think now 1 extra meniscal stitch going in at the very end just for good measure, just because I'm a bit paranoid. And that's our meniscal repair. So that patient's meniscus has been salvaged rather than almost completely removed. Now this poses a bit of a problem. This is a very, very unhappy picture if you're the person who's funding the surgery, like the NHS or the insurance company. A very happy picture if you work for Striker. Each of these meniscal repair devices costs about £300 each. And just to be fair to Smith & Nephew, you'll notice that there's a Smith & Nephew knot cutter, so at least they haven't been completely left out. Now, this does pose a major problem in a healthcare system where the tariff for an arthroscopy of any kind, because it doesn't really describe what's done inside the knee, the term arthroscopy, is particularly low. The kit that we use may massively actually exceed the amount of money the hospital is being paid for the procedure, for example, in the NHS. And that's so funding for this kind of surgery with this kind of kit is a potential issue. So with meniscal repair, well, how many are repairable? The literature is really unclear about this, but approximately maybe 15% or so are repairable. In my practice, I audit what I do, and I repair just over 30% of the tears that I see. It's probably an unfair comparison because, number one, I see younger patients because I'm based normally in the city, and number two, I've got particular interest in meniscal repair, so my threshold for attempting a repair will be lower. In terms of success rates, well, the best published papers suggest a success rate in the region of 90%, which is great. But the flip side is always that means that 10% of the time you may stitch a meniscus, it doesn't mean it will heal. Or even if it does heal, it doesn't mean it will stay healed. In other words, they can re-tear. And that's critically important that you discuss that in detail with the patient during the consent process in advance of any surgery. So finally, replacement. Well, what do you do if you've lost a meniscus and as a result of the meniscectomy you're beginning to develop progressive symptoms and signs of early degenerative changes in that knee, but you're still young, too young for a knee replacement, the damage is not bad enough for a knee replacement, but you're going downhill? Very simple. If you've lost your meniscus, you simply replace it. This is a meniscal allograft supplied on a bone block. This is the meniscal allograft prepared. This is an old picture. I don't use these sutures anymore. This was fibre wire. I now use suture tape or fibre tape, which gives a better hold, and I do a double suture in the anterior posterior horns for a better hold. So this is the medial compartment of somebody's knee with the medial meniscus should be coming around here, but it's missing, and some early roughening and thinning of the articular cartilage on the medial femoral condyle. And this is the medial compartment with the meniscal allograft in place. Well, most importantly, does it work? Well, back to the pressure studies. This is a cadaveric lab-based study. 2D here, same picture in 3D. Intact meniscus, wide contact surface area, low peak contact pressures. Take the meniscus out, small contact surface area, much higher peak pressures. If you put a meniscal allograft in, the contact pressures are reduced towards, not quite perfectly too, but towards normal, but much, much better than the meniscectomized knee. Clinically, does it work clinically? Well, this is probably the best paper in the literature, and it's from the ESCA journal, and this is from Verdonk and Verdonk from Belgium, and it provides a 26-year view of meniscal transplantation, because this is not new. Meniscal transplantation was first reported in the English-speaking literature in 1988 or 9, I think it was, by Klaus Middekowski from München in Germany. So it's been done for a long time, and if you look at the results, then approximately 80 to 85% success rate at 5-year follow-up, which is reasonably good, but that's very important. You have to explain to the patient that 15 to 20% failure rate within 5 years. So is it good? Yes. Is it perfect? Absolutely not. And if you want to know more about meniscal transplantation, then go to this absolutely great website called meniscaltransplantation.com, and I've put a huge amount of extra information on there if you want to find out more. So thank you for listening. That was an absolute whistle-stop tour of flying through the meniscus. There's loads more. You know, I could talk for hours on the meniscus and never get bored of my own boring voice, but I've tried to keep to roughly 20 minutes, and so hopefully now we've got time for some questions. Okay, so lots and lots of factors. So first thing is the age of the patient. The younger the patient, then the harder I will try my very best to repair a meniscus in a kid, a teenager, a young adult. Far more likely to do a meniscectomy, partial meniscectomy, if the patient is older. And that's not ageism, it's simply that the younger you are, the more likely it is your meniscus will be in better condition. So a more solid meniscus, not frayed, not soft, not degenerate, with a better blood supply, with a better chance of healing. Also, the younger you are, the bigger the consequences of meniscectomy, because young people, A, are more active, and B, live longer. So it's much worse to lose your meniscus if you're young than it is when you're old. So age is a key determinant. Second thing is the type of tear. If you have a vertical peripheral circumferential tear, which is in the red zone, then they're more likely to be repairable. If, for example, you have a ragged complex degenerate tear, then no, that's almost never going to be repairable. Some horizontal tears may occasionally be repairable. You may be able to do a partial trim and a partial repair. Radial tears are rarely, if ever, repairable. There's only 1 or 2 times when I've performed a meniscal repair for a full width radial tear in a teenager, in which case it's worth the attempt, but that is a very complex and very difficult type of tear to repair indeed. So it really does depend on that, and then it depends on the quality of the tissue. And when you do an arthroscopy, you inspect and you probe the meniscus, and you get a very good idea very quickly what kind of what kind of condition the tissue is in. If it's soft, if it's ragged and friable, you're not going to be able to repair it. So it's multifactorial, and the difficulty is obviously that if there's even a hint that you might perform a meniscal repair instead of a meniscal trim, then that's a very, very detailed, lengthy, complicated discussion you've got to have with the patient in terms of what that means to them, in terms of additional risks, and also much slower rehab. Yeah, it's both. It's patient and procedure specific. With a meniscal trim, everybody knows you get fully weight bearing straight away, crutches for the first couple of days just for comfort and safety. Take it easy for a week, then get stuck into your rehab treatments. And allegedly, people plateau in the recovery within about 6 weeks. If you have a meniscal repair, then, and it does kind of depend on the severity of the tear, the complexity of the repair, and your confidence level on how mechanically strong that repair might be. But generally speaking, with a repair, you would tend to put somebody on minimal toe touch partial weight bearing with 2 crutches, with their knee in a hinged brace locked at 0 to 90 degrees to protect the meniscal repair for the first 6 weeks, before then starting a gradually progressive course of physio rehab treatments, only going back to impact and loaded twisting by 3 months post-op at the earliest, as long as the physio says the patient is ready by then. So much slower, much more cautious approach with a meniscal repair. Yeah, good question. How do you train? I think, I can't remember really, and this is a long time ago now, but I can't really remember when I was younger, when I was a SPR, but it was a different era back then. I can't remember seeing many, if any, meniscal repairs. I saw a lot of stuff chopped out. When I turned up to Ealing Hospital as a fresh consultant, the first question I asked in the theatre department was, what kit have you got? What meniscal repair kit have you got on the shelf? And they said, none. I was like, oh, wow. So speaking from experience, very little, and it's almost, as a consultant over the last 15 years, whatever it is now, I've just gradually learned just by doing it and just getting more and more experience. I think things are very different now. The era of just have a go or do one, see one, teach one is historical, and patient safety comes first. So I think hopefully registrars are seeing meniscal repairs being done, and most importantly, if you want to be a knee surgeon nowadays, then generally speaking, most registrars will have done a knee fellowship with somebody who is specifically into what they want to do, like sports knee surgery. In which case, if you spend time with somebody who does lots and lots of sports knees, then you'll almost definitely, unless there's something seriously wrong with that surgeon, you'll almost definitely see a fair amount of meniscal repairs. If you're a consultant, then it's very, very difficult to say, well, you'll go and visit another consultant to learn how to do meniscal repair, because it's very difficult to predict which patients will or won't actually have a repair, because it depends what you find when you're in there. So that was a really rubbish answer to a really good question. Sorry about that. All I can say is it's really difficult, and it just takes time. Yeah, two very, very different situations. Meniscal repair, if somebody's got a medial meniscal tear and they have a varus knee, it's very, very different to do an arthroscopy and a meniscal trim, or an arthroscopy and a meniscal repair as an isolated procedure versus combining it with a realignment osteotomy. A realignment osteotomy is a really big, nasty operation, much, much more invasive, much bigger, much more painful, much bigger risks, much slower recovery, much more scary potential complications. So realignment osteotomy surgery is absolutely not trivial. If you've got somebody who has got malalignment and they've got any kind of degenerative changes or articular cartilage or meniscal damage in the overloaded compartment, then yeah, you can absolutely guarantee that, not guarantee, you can be highly confident that they will be at much greater risk of further problems in the future. So I would say if it's a meniscal tear you're dealing with a malaligned knee, I would say deal with the meniscus, but you should also have a discussion with the patient about the malalignment, and maybe consider realignment surgery later on if it's really proved necessary. And that very much depends on how the patient feels after they've got over their arthroscopic surgery. Completely the opposite way around, completely different when it comes to meniscal transplantation. One of the absolute key factors in assessing somebody as to whether they're suitable or not for a meniscal transplant is alignment and stability and the extent of the degeneration. If somebody has malalignment and they're overloading the affected compartment, then you basically have to do an osteotomy. If you've got a young patient, then you can justify doing an osteotomy and a meniscal transplant as a combined procedure to give them the best possible chance of a good long-term outcome. However, that's very, very difficult, very major surgery to combine two big complicated operations into one massive one. So if you're going to do one first and one second, then you're always going to do the osteotomy first. Equally, if you're going to do just one operation between a meniscal transplant or an osteotomy, then you go for the osteotomy every time. And if you've got an older patient who is, say, 45, 46, 49, then you'd be far, far more likely to do the osteotomy only and not bother doing the meniscal transplant at all, because there's a limit to what's sensible. The answer to that is yes. Different people have tried different things. The Japanese, there are some papers published about using fibrin clot, and that was published quite a long time ago. That showed that it did enhance the repair, improve the repair rate. Some people might inject PRP. I personally use something called PRF, platelet-rich fibrin, and that's something called Vivostat, V-I-V-O-S-T-A-T, Vivostat PRF, platelet-rich fibrin. And what that means is, in the anaesthetic room, the anaesthetist takes 120 mils of the patient's blood, spins it down. You've got a tower, like a centrifuge, so you spin down the blood, and half an hour later that gives you 5 or 6 mils of platelet-rich fibrin. So fibrin is like the sticky part of a blood clot, but it's got an 8 times concentration in platelets. So it's like an autologous biological glue. So that then once you've done your repair, then you spray your repair over with this glue, and the platelets release growth factors over the course of the first 7 days, which allegedly increase healing. And what it also does is it creates a seal over your meniscal repair, because what you don't want is synovial fluid getting into that interface between the two surfaces that you're pushing together. If there's fluid there, it'll never heal. So it acts as a sealant, and it's bioactive. You don't use it as a glue for any kind of mechanical properties. Now, I use that Vivostat PRF for every single meniscal transplant that I do, because I stitch the meniscal transplant in and then I glue it around the edge. Again, biological glue. The problem when it comes to meniscal repair is that a lot of the time you can't really be certain whether you're going to do a repair or a trim until you're actually in there. And if you're in there and then you take 120 mils of blood and wait half an hour and spin it down, well, that's not very practical. So the times when I've used biological augmentation for meniscal repair have really been in cases where you've got a young person, so a teenager or a very young adult who's high functional demand, and you absolutely want to try and do meniscal repair at all costs if possible. So in that case, then what we quite often do is get the Vivostat ready at the beginning of the procedure, and if it's needed, great, we use it. If by any chance it turns out that it's not needed, then you just discard it. It's slightly wasteful, but we do that on occasions. The other way of doing a biological enhancement is to trephine the rim. So what you do is you get a spinal needle that's slightly bendy, so you can poke around different corners. And what you do is you poke lots of holes into the peripheral rim of the meniscus to make that peripheral pericapsular peripheral capillary plexus. You can to make it bleed. So if you make the meniscal rim bleed with lots of little holes, then it's more likely to heal, and that's another form of biological enhancement. Do I believe that PRP, platelet-rich plasma, completely different from PRF? So do I believe that PRP improves meniscal repair rates? No, I don't. I haven't seen any convincing evidence of that at all. I've forgotten his name now, I'm very sorry. There's a guy from Poland, and he presented at the either ESC or ICRS, I can't remember now, sorry, I'm getting senile. So some bloke from some country somewhere presented at some meeting that I heard some time ago. You know, that shows just how lockdown's making us all go senile. He's done a study looking at biological enhancement, and he's done a prospective control study, and that's the only one I've seen. There might be others out there. I would love to be able to do that, but it's just totally impractical. And that's because it would have to be a prospective study, and it would have to be randomized and controlled. And if you've got something that you believe enhances meniscal repair, and if you as a surgeon firmly believe that, then, or if you firmly believe it, if you believe it does, and you explain that to the patient, and I work full-time in private care, so the patient wants you to give the very best treatment with the very best procedure that you possibly can. And if you say, yes, I've got something that we think enhances repair rates, but I'm going to flip a coin as to whether you get it or not, then there's not many private patients that would be happy to enter that study. So unfortunately, I would love to be able to do that study. I think there is a need, very much a need for that study to be done about biological enhancement, but it's going to be a very, very difficult one to recruit patients into and to get the numbers up sufficiently to have any kind of statistical power. If you're a sports knee surgeon, if you're an arthroscopic knee surgeon, then you've got to be able to do every single one of these meniscal repair techniques, and there's lots. So you've got to be able to repair root tears with transosseous tibial tunnels, okay, using things like the Scorpion, and that's completely different technique from what I've shown on this presentation. So you need to know how to repair a root avulsion. Ramp lesions, that's a separate topic. In terms of the main alternative technique I do is outside in, and I use the Smith and Nephew meniscal needles for this with little wire lassos, and that's where you put a needle from the outside in to the knee, and that's for stitching the anterior horn, because it's almost impossible, in fact it probably is impossible, to stitch the anterior horn in place properly with an all-inside meniscal device. So I use outside-in sutures, and again I use suture tape or ultra braid, as well as all inside. So you've got to know every single technique basically. Yeah, I don't tend to do inside out meniscal sutures. I don't like them around the back. I just think they're too dangerous. I'm too scared of causing neurovascular damage. And for the body portion of the meniscus, where you could use a sharpshooter and you could use the inside out technique there, I just don't think you need to, because if you've got a bendable striker air, then it can get around all the way to the junction between the body and anterior horn portions. So you just don't need to do an inside out. You can do it all inside. That's really, really difficult. I think it's definitely an option. And when you say recommend, really, the best way to put that question is it something I would recommend to my patients? Right, not is it something I would recommend to other surgeons. I think this is a really difficult discussion you've got to have with your patient, and you've got to explain that if you've got malalignment, you're overloading that meniscus, there's a higher chance of whatever you do to that meniscus failing, and therefore there's an argument for doing the offloading osteotomy, and there's an argument for doing it all at the same time, especially if it's a root avulsion. So I think there is an argument there, but the patient needs to understand that they're talking about a much, much bigger operation. I mean, technology is going to make everything from that perspective a lot better. It doesn't replace good old-fashioned hands-on experience, but yeah, it's the old adage of see one, see one, try one, or see one, do one, teach one. That's it. It's very old-fashioned. It's fantastic for learning for the surgeon. It gives them a very, very steep learning curve, so they get up that curve quickly. I wouldn't say it's fantastic for the patient to be a guinea pig. So the more, I think the proper way of doing this would be lectures, reading, papers, academia, so theory. Then one step up from that is playing with the actual devices on, plastic model menisci, for example, or for example, using saw bones. One step up from that is a cadaveric lab where you're using a cadaveric knee wet with an arthroscopy stack, and you're using all the kit. Then one step up from that is to do it real life, but with an experienced surgeon there talking you through it, holding your hand, literally holding your hand sometimes to guide you and overseeing what you're doing. And then only when you feel confident and they have confidence in you should you then go and do it live on a real patient, for real. So I think there's a progression. There's a progression of steps in terms of getting as good as you can to be as safe as you can before you're let loose on the general public. And I think virtual reality, 3D goggles with haptics as well, so you get tactile feedback. I think it's absolutely guaranteed at some stage to become a standard part of all training programs. No specific age cutoff. It's about the physiological age of the patient and the state of their knee and the state of their meniscus, as opposed to chronological age. And the oldest patient I've ever done a meniscal repair in was 65, and that healed successfully. And he had a knee that looked absolutely pristine, with a meniscus that looked like a 20 or 30-year-old's, and he was very active. He was a runner. So 65 and
65, yeah.
No specific cutoff.
Mm-hmm. Is there an average that you usually see in terms of age?
I would say, if you just ballpark figures, I think probably 40. 40-ish is a good number. The younger you are under 40, the more likely you are to be suitable for a repair. The older you are over 40, the less likely. But that's not a cutoff. That's like a curve with a hump. It's not a brick wall. Right. Diagnostic arthroscopy is anathema, really, because there's two scenarios where you have a diagnostic arthroscopy. Right. The first scenario is you look inside and you find there's nothing wrong. So it's a diagnosis of exclusion. You think there might be something wrong in a knee, you look inside and there's nothing wrong, or at least you can't find anything wrong. Well, that's great news for the patient. You wake them up and you say, good news, nothing wrong with your knee. Right? Well, actually bad news, because you haven't given them a diagnosis of what their symptoms are, and if they haven't got symptoms, then what the hell are they doing on the operating list? So you haven't identified their symptoms, you haven't given them an answer, but you subjected them to the pain, the hassle, the risk of an operation and an anaesthetic with no real gain, apart from a bit of reassurance. But I would not find that particularly reassuring if somebody said, I couldn't find anything, right? Because I wouldn't go for an arthroscopy on my knee unless I had really significant enough symptoms. So I wouldn't say that's good news. A second situation where you do a diagnostic arthroscopy is because you look inside somebody's knee and you find something you can't deal with. So you're diagnosing it, but you're not treating it. You're not treating it because either you're not experienced in that particular problem or you haven't got the right kit. Well, that's just down to bad foresight and bad planning. So if I was going to have if I needed a complex procedure on my knee, I would want my arthroscopy done by somebody who's capable of doing the bigger the procedure. So, sorry, the bigger procedure as well. So it's diagnostic to confirm the diagnosis and therapeutic because whatever you find, you deal with. So this concept of diagnostic arthroscopy is uncomfortable, to put it mildly, because in a situation where you've got somebody who's like got medial OA and you're thinking, well, are their lateral and patellofemoral compartments good enough to do a medial uni instead of a total? Well, just get an MRI scan. So that's not a good excuse for a diagnostic arthroscopy. So no, I don't like the term diagnostic arthroscopy. Personally, to me, it reeks of failure in one direction or the other. Okay. You know, many of us have tried the synthetic scaffolds in the past, and the two main scaffolds are the CMI, which is the Menaflex, which is made from pressure molded bovine Achilles tendon collagen, right? And the other one is the Activit, which is made from polyurethane. And initially, it's all very exciting, and you think, my God, that's fantastic. However, number one, they can only be used for segmental defects, not to replace the whole meniscus. And number two, the peripheral rim needs to be in continuity because you stitch it into the peripheral rim. So if there's any discontinuity around the peripheral edge of the meniscus, you can't use them. So the indication is quite narrow. Now, that means that you can only use them for replacing smallish bits of meniscus. Well, if only a smallish bit of meniscus is missing, then the first question is, well, do they really need anything replacing at all? That's the first question. Second question is, well, is anything better for replacing meniscal tissue than meniscal tissue? And the answer is no. So with these scaffolds, what allegedly happens is that tissue grows in and then it remodels and you grow new meniscus, but it doesn't. So with the Menaflex, the studies have shown that only 74% of the missing volume of tissue grows back, not 100%, but very importantly, the tissue that grows back is effectively scar tissue. It's not meniscal tissue. You do not grow circumferential collagen fibers that grow back in place and heal at one end and go all the way around and back to the other end to give meniscal function. So no, they don't work biologically. The studies have shown that if you do a meniscal scaffold, you can reduce a patient's symptoms, right? But from practical experience, most of the people I know who've tried, including myself, who've tried using meniscal scaffolds because initially they were quite encouraging, have given up fairly quickly because we've seen an unacceptably high failure rate because they tear, they shrivel, they shrink, they tear, they become ragged, they fail, they need further surgery. So my answer would be, at this stage, with the technology that is available currently, there is nothing better for replacing a meniscus other than a meniscus. In other words, a meniscal allograft from a donor.